we're breaking down two endocrine disorders that love to show up on exams and in clinicals. SIADH and DI. That's Syndrome of Inappropriate Antidiuretic Hormone and Diabetes insipidus. But before we talk about those, let's talk about ADH, because understanding it will make everything else a lot easier. Let's get into it. ADH, or antidiuretic hormone, is made in the hypothalamus and stored in the posterior pituitary gland. Its job? To tell the kidneys to hold on to water when the body needs it. When you're dehydrated, ADH steps in and says, hey, don't get rid of that water. So your urine becomes concentrated and dark. But if you have too much water, ADH takes a break and your urine is diluted and clear. In simple terms, ADH prevents you from peeing too much. Now, let's see what happens when the body makes too much or too little of it. First up, SIADH. This happens when the body produces too much ADH, leading to excessive water retention. Think of ADH as a little worker that tells your kidneys to keep water in the body. Too much ADH? You hold on to way more water than you need. In SIADH, the blood becomes diluted, leading to low sodium levels, also called hyponatremia. Symptoms include fluid overload, so you'll see weight gain and edema, low urine output, because the body isn't letting go of water, and concentrated urine, urine that's dark and full of solutes. You may also see neurological symptoms like confusion, seizures, or even coma due to low sodium levels. Think of it this way. If I have a glass of water and I add just a pinch of salt, it's very diluted. This is what happens in SIADH. The blood gets too watery and the sodium gets too low. What causes SIADH? Some of the big ones include lung cancer, especially small cell lung cancer because it can release ADH. Head trauma or brain tumors, since the pituitary gland controls ADH, and medications like SSRIs, anticonvulsants, and some chemotherapy drugs. So if you see a patient with unexplained fluid retention and low sodium, check their history for these causes. Now, how do we treat SIADH? First, we're going to place the patient on fluid restriction, which is usually about 800 to 1,000 milliliters a day. Then we're going to administer hypertonic saline in severe cases, but please give it slowly. We're going to also administer diuretics like furosemide to get rid of excess water. Now, let's switch gears to diabetes insipidus, or DI. This is basically the opposite of SIADH. DI is too little ADH, meaning the body gets rid of too much water. Patients with DI are like a desert. They're super thirsty and losing tons of water. With DI, the kidneys don't hold on to water, so we see polyuria, which is excessive urination, sometimes 10 liters per day. Polydipsia, which is excessive thirst to make up for the fluid loss. And then we can see dehydration leading to dry skin. This dehydration will also cause low blood pressure and even an increase in heart rate. You will also see hypernatremia since the blood becomes too concentrated. What causes DI? There are two main types: neurogenic DI, where the brain doesn't produce enough ADH, and causes include head trauma, brain surgery, and tumors, even a stroke or infection affecting the pituitary gland. The second type of DI is nephrogenic DI. This is when the kidneys don't respond to ADH. Causes for this include kidney disease, and lithium toxicity. How do we manage DI? For neurogenic DI, we're going to give the patient desmopressin or DDAVP, which is a synthetic ADH to replace what's missing. We're also going to monitor for overhydration if treatment works too well. For nephrogenic DI, we're going to place the patient on a low-sodium diet to reduce urine output. We're also going to administer thiazide diuretics. Yes, a diuretic, but it helps the kidneys retain water in this case. In short, SIADH equals too much ADH, so we do fluid restriction, and DI equals too little ADH, so we replace it. All right, quick review. SIADH means soaked inside, so you're going to have too much ADH, fluid retention, and hyponatremia. For these patients, we're going to place them on fluid restriction, give them hypertonic saline, and diuretics. For DI, that means dry inside, that's too little ADH, excessive urination, and hypernatremia. And for those patients, we're going to administer desmopressin for neurogenic DI and thiazide diuretics for nephrogenic DI. I hope this helped. Share with your classmates, and I'll see you in the next study session.